Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello and welcome to Management of Early Alzheimer's Disease, Merging Clinical Data and Clinical Decision Making. I'm Dr. Sharon Cohen, behavioral neurologist at Toronto Memory Program in Toronto, Canada. And our course director, Dr. Ronald Peterson, deserves credit for pulling this all together. He is the professor of neurology at the Mayo Clinic in Rochester, Minnesota. Let's begin. We want to cover practical use of amyloid-lowering therapies in this activity, and we'll start with clinical data. Then we'll talk about who are the appropriate patients and how do you monitor and follow patients on amyloid-lowering therapies. Let's start with an overview of the therapies and the data that has led to their approval. Lecanemab and donanemab are two monoclonal antibodies that target aggregated amyloid, and they are approved in the US and other jurisdictions for the indication of biomarker-confirmed early AD, with early AD referring to the MCI or mild dementia stage of Alzheimer's disease. These drugs are administered by intravenous infusion. Lecanemab, a 1-hour infusion every 2 weeks up until 18 months, and then the option to switch to every 4 weeks infusion. And donanemab, a 30-minute infusion given every 4 weeks. There is a side effect called ARIA that we'll talk about in more detail that is related to this class of monoclonal antibodies. And there's a requirement for MRI of the brain to look for eligibility and to monitor for ARIA. If we look at the large phase 3 pivotal trials that led to approval of lecanemab and donanemab, we see the Clarity AD study with over 1,700 patients for lecanemab, the donanemab Trailblazer-ALZ 2 study with, again, over 1,700 patients, and these were international trials. And when we look at the target population, it was MCI, mild dementia due to Alzheimer's disease with amyloid confirmation in Clarity AD by amyloid PET or CSF, and in the Trailblazer-ALZ 2, confirmation by amyloid PET. Now, tau pathology was not required to be demonstrated in Clarity AD, although there was a tau PET substudy. For donanemab, tau PET was important as an inclusion criteria because patients were actually stratified by their level of tau PET burden. MMSE scores for lecanemab trial were 22 to 30 and 20 to 28 for the Trailblazer-ALZ 2 study. Age range 50 to 90 for lecanemab and 60 to 85 for donanemab. And importantly, background medications for Alzheimer's disease were allowed, including symptomatic treatments, both cholinesterase inhibitors and memantine. And patients could also be on anticoagulants, low-dose aspirin, and other antiplatelet therapies. If we look at the baseline characteristics for Clarity AD and Trailblazer-ALZ 2, what we see from this table is that we have a greater proportion of patients in the lecanemab study who have mild cognitive impairment, while in the donanemab trial, we see more at the mild dementia stage of Alzheimer's. We also see biologically greater amyloid burden at baseline in the donanemab trial. We see further, and not unexpectedly then, a little bit lower MMSEs at baseline, around 22 for the donanemab group, and closer to 26, 25.5, 25.6 in the lecanemab Clarity AD study. Symptomatic medications, a little bit more in use in the donanemab trial. So this all adds up to the donanemab trial, including a little bit more advanced clinically and a little bit more advanced biologically patients, even though they had MCI or mild AD dementia. Let's turn now to key outcome measures. What we see first with lecanemab is very robust lowering of amyloid plaque on PET scan, starting as early as the first time point, 3 months, and expanding out to the 18-month duration of the trial, with 68% of patients being amyloid negative on PET at 18 months. If we look at clinical outcomes, the CDR sum of boxes, which was actually the primary outcome in this trial, we see 27% less decline in progression of disease on the CDR, which is both a functional and a cognitive scale. It's a global measure. And a time savings of about 5.3 months, meaning that the placebo group declined 5.3 months earlier than the lecanemab group. Similarly, with the ADCS MCI ADL score as a functional outcome, we see an even greater slowing of disease progression, 37% less decline on this scale. And again, function is so important to patients that this is a very important outcome geared to early AD. And for both these clinical measures, we see that we get separation from placebo as early as 6 months, and the magnitude of effect increases over time out to the 18-month duration of the trial. We see a very similar kind of result in the outcomes for the donanemab study. We see amyloid plaque lowering being very robust. By 18 months, we see 76% of individuals in the overall group being amyloid negative and 80% amyloid negativity in the low to medium tau group. If we look at clinical outcomes in this trial, the iDRESS on your lower right was actually the primary outcome for clinical measures. And we see about 35% less decline on iDRESS, which is a combination of a functional and cognitive scale. With the CDR-SB, which was a secondary outcome in the low to medium tau group, we see 36% less decline compared with placebo. So this amounts to a delay in decline of about 7.5 months. Another way to look at this data is to look at time to progression to the next clinical stage on CDR global staging. And importantly, both drugs delay the risk for progression to the next more disabling stage of disease. So, whether you start at the MCI stage or start your treatment at the mild dementia stage, you have with lecanemab 31% less risk of progressing to the next stage on CDR global. And similarly with donanemab, 38.6% less risk of progressing to a more disabling stage. There are models now that also can predict time saved. And saving time at an early stage of disease when people are still independent, living in their homes, functioning reasonably well, is the ideal time to capture extra time. People value that. What you see here with lecanemab is a savings of 10 additional months when you model out to 72 months. With donanemab, you see 13 additional months in the low to medium tau group and 8 additional months in the overall group. So again, we'll come back to this later, but you see that the low to medium tau group actually fares better than when you add in the higher tau group. Is earlier treatment better? There are several ways to try to answer this. And if you have a patient who may say, "Oh, I'm doing okay now, why don't I wait with treatment until I've progressed?" You might want to have a look at this type of data I'm going to show you here, which really indicates that treating early gives better results. When we look at post hoc analysis from Clarity AD with lecanemab, what we see is when we get to the open label extension at 18 months, where we no longer have a placebo group, the delayed start group in black, um, switching to green, doesn't actually catch up to the people who were treated from the beginning. And if you can imagine taking out in the right-hand chart the delayed start group and look at the ADNI control, and you see up until 18 months, the ADNI control group is right on top of the placebo group. And if you extrapolate that out, or actually use ADNI data right out to 36 months, you get a widening of effect. So increasing magnitude of effect for those who started lecanemab on day one. So you go from a CDR difference of 0.45 at 18 months out to a CDR change score of 0.95 at 36 months. So earlier treatment is better here. And we can think of this as the delayed start, don't catch up. Another way to look at this that has been examined post hoc in Clarity AD data is looking at the biologically milder patients. Yes, they had MCI or mild AD dementia to get into the study, but when they were involved in the tau PET sub study and we could see whether they had no tau or very low tau, these individuals actually got stability or improvement. And while we think of these monoclonal antibodies as slowing disease and not necessarily improving people, there are a percentage of people who actually improve. Similarly, if we look at the low amyloid group through the amyloid PET scanning that was done uh, after baseline and into treatment, then we see those who have low amyloid at start of less than 60 centiloids actually, again, showed stabilization in many of them or improvement. So, again, speaking to the fact that earlier is better. Here we can see a comparison of the low medium tau population and the overall population in Trailblazer ALS 2. And remember, the overall population includes the high tau individuals. And what you see, whether it's on the iDRAS or the CDR-SB, is that most of the benefit, the slowing of decline, is derived from the low medium tau population, and you don't really get quite as much separation when you add in the high tau group. And finally, here we look at donanemab modeling, and we see something that we referred to before, that the time saved is greater when you look at the low medium tau group and on the CDR, savings of 13 months compared with placebo, compared with the high tau group who save only 4 months. So we don't want the disease to advance clinically or biologically, however we measure it, and then start treating as early as you catch this disease. If a patient is eligible and wishes to embark on treatment, we would encourage that. Let's turn to safety. Every drug has side effects, and it's important to understand some of the unique side effects for these anti amyloid monoclonal antibodies. Infusion reactions, this is not rare, and many of you will be familiar with infusion reactions from other drugs. Whenever you infuse a protein, there's a chance of an infusion reaction. The rates for lecanemab are about 26%, but fortunately, the infusion reactions with lecanemab are serious in only 1.2% of patients, so very low risk of serious side effects or infusion reactions. For donanemab, it's a lower rate for infusion reactions, 8.7%, and serious infusion reactions, 0.4%. Importantly, infusion reactions with these drugs generally occur after the first dose and rarely recur. There's an option of slowing the rate of infusion if a reaction is happening, or stopping the infusion depending on the severity of the reaction. That's usually not necessary. And also, consideration can be given to pre-treatment if someone tends to have recurring infusion reactions. For the most part, infusion reactions were not a deal breaker in the phase 3 studies. Moving on to a separate side effect, ARIA, we should spend a little bit of time talking about this. This is something that is not familiar to most of us who have been treating Alzheimer's disease with symptomatic therapies. So, ARIA stands for amyloid related imaging abnormality, and it can occur spontaneously in untreated patients, but has become a prominent topic of discussion as a class effect with amyloid lowering therapies. And what is ARIA? ARIA comes in two types, ARIA E, and the E stands for edema or effusion. ARIA-H, with the H standing for hemosiderin deposits, and again, two types, can be microbleeds or superficial siderosis. And you need particular MRI sequences to bring out these two types of ARIA, so FLAIR imaging sequences for ARIA-E, and you can see where the arrows are pointing to areas of ARIA-E on your left, and on your right, these little holes in the brain, tiny little holes. These are microbleeds or ARIA-H, um, as seen with rapid sequences, T2 star or GRE sequences. So ARIA sounds very scary to patients, swelling in the brain, spots of bleeding. Important to know that these phenomena tend to occur early in treatment. They are typically asymptomatic, so 75% of the time, no symptoms. We wouldn't know they're happening if we didn't do MRI monitoring. They are usually, when they occur, mild to moderate in terms of symptoms, if symptoms occur. And symptoms can be rather nondiscrete headache, dizziness, unsteadiness. It is uncommon. It is decidedly rare to have serious ARIA-E, but because serious ARIA-E can happen, even rarely, it's important that we monitor for this and know how to manage and prevent it if possible. So serious ARIA-E occurs with lecanemab in less than 1% of cases, 0.8%. With donanemab, a little bit higher, 1.5% of individuals will have serious ARIA-E. Most ARIA resolves spontaneously without any intervention, and that's also reassuring to patients. So we want to manage it, we want to monitor for it. It's mostly transient, mostly asymptomatic, but those rare cases of serious ARIA we don't want to miss. Here, what you see are a comparison of the rates of ARIA in the phase 3 trials we've been talking about. So, ARIA E across the top and ARIA H across the bottom. And when you look at this, what you see is for the lecanemab group in the lecanemab trial, the ARIA rate was 12.6%, whereas with donanemab, 24% of individuals had ARIA E. For ARIA-H with lecanemab, 17.3%, with donanemab, 31.4%. So you can see that the rates of ARIA, whether it's ARIA-E or ARIA-H, are dependent on the antibody itself, not just the class of drug. ApoE4 is an important predictor of ARIA or a risk factor for ARIA. We know ApoE4 is a risk factor for developing Alzheimer's, but it is also a risk factor for ARIA. And how does this work? Here you see again the lecanemab and donanemab trials, ARIA-E across the top, ARIA-H rates across the bottom, but broken down now into non-ApoE4 carriers, heterozygous ApoE4, and homozygous ApoE4. And whether we're dealing with lecanemab or donanemab, we see this increasing rate of ARIA depending on ApoE4 carrier status and copy number, with homozygotes having the highest rates. If you look at ARIA-E for lecanemab, 32.6% of homozygotes had ARIA-E with lecanemab, and up to 40.6% with donanemab. For ARIA-H, we see with homozygotes, 39% had ARIA-H, and with donanemab, up to 50.3% had ARIA-H for the homozygotes. Even so, most of this ARIA is asymptomatic and resolves spontaneously, but these higher rates are important to keep in mind. And here, looking at placebo, we see that you're never going to get no ARIA because ARIA is part of Alzheimer's disease. Amyloid infiltrates the blood vessels, not just the brain parenchyma, and causes the blood vessels to be leaky, causes leakage of not just hemosiderin products, but also effusions. So we do get ARIA E and ARIA H in untreated patients at a low rate. A different trial with donanemab called Trailblazer AL6 has demonstrated the potential for reducing ARIA by titrating the drug more slowly. So rather than the usual titration of donanemab starting with 700 milligrams for the first 3 doses and then switching to 1400, we're starting now with 350 milligrams and titrating gradually. And in this Trailblazer AL6 study, there was a reduction, a substantial reduction, as you see in the lower panel circled in orange, in rate of ARIA with this what's called the modified titration scheme. So, how do we manage ARIA risk? How do we try to keep our patients safe? Baseline MRI is important. So, pretreatment MRI will give us an idea of how much CAA there is. And even though by FDA label, there's no specific cutoff, many of the appropriate use recommendations or specific institutional guidelines want to make sure we're not exceeding a certain number of microbleeds or showing macrobleeds. So, specifically, we don't generally treat individuals with these antibodies if they have a macrohemorrhage, if they have an area of superficial siderosis, or more than 4 microbleeds. So, that's on the pretreatment MRI. Then having the ApoE genotype known, tested for, discussed with patients. This will help individualize the risk and therefore the benefit risk discussion with patients. Blood thinners are not prohibited by label. Antiplatelet agents are felt to be safe, but the AURs will caution against anticoagulant use, and it'll be an individual decision or an institution by institution decision as to whether individuals on anticoagulants can or should be on anti amyloid lowering therapies. So it's important that we get good communication going. We need to speak to our radiology colleagues. We need to make sure they're using the right MRI sequences, that they understand the kind of report that we need back in order to make treatment decisions about holding the drug or continuing with infusions. We need to be communicating with our patients and within teams here. We need to make sure our infusion center, if it's not on site where we're practicing, is ready and able to handle infusion reactions. So, again, good communication all around is key. We want to make sure we're well set up for success with implementation of amyloid lowering therapies. So, protocols as part of the clinical evaluation are helpful. Maybe tick boxes, checklists. Does the patient have MCI or mild dementia? Do we have confirmation of amyloid pathology? Have we got a baseline MRI? Has the ApoE genotype been checked and discussed? So, these kinds of things are very helpful to have in a systematized flow. And then what's our infusion protocol? Is our infusion center or our infusion nurses all on the same page about rates of infusion, post infusion monitoring, how to deal with infusion reactions? In terms of ARIA safety monitoring, we need to make sure that we are receiving MRI reports and signing off on them before the next dose of the monoclonal antibody so that we know we're not dosing through ARIA that may be of significance. And we need to also make sure that our radiology colleagues in in acute care hospitals who may be dealing with an acute stroke situation are aware that they need to explore for ARIA if a patient's on an anti-amyloid monoclonal antibody. And finally, we need to think about ongoing assessments. Are patients benefiting? Is a patient declining precipitously? Are they staying relatively stable and appear to be benefiting from the drug? And at each point along the way, we need to have dialogue with patients and perhaps their families to see how they feel about continuing treatment. So here's a workflow that it summarizes what we've just talked about. You need clinical diagnosis with biologic confirmation, MRI pre-treatment to ensure that you've got the right patient who's safe to dose, no macro bleeds, etc. You want to make sure you have amyloid verification by PET or CSF, ApoE testing done and discussed with patients and families, and broader discussions regarding what the patients would value and what their goals are for treatment. The goal is ultimately to preserve cognition for as long as possible, to delay decline in daily function, to preserve quality of life for both patient and care partner, and to provide patients with more time to pursue activities of value to them at earlier stages of disease when they are still relatively independent and living in their own homes. If we look at the eligibility for treatment, in the top uh, panel, you'll see required by labels in blue. MCI or mild dementia due to Alzheimer's disease, evidence of amyloid pathology, able to tolerate multiple MRIs. So if a person is claustrophobic or has a pacemaker, they are not likely candidates here. CT is not going to be adequate. And we need to be aware of cautions regarding CAA. Additional eligibility requirements, either through the appropriate use recommendations or as implemented in some institutions, will include MMSE or MoCA cutoffs to ensure that early AD population. ApoE4 testing may be required, not just recommended. And MRI exclusions may be more spelled out in certain institutions or by the AURs. A reliable care partner to report on how patient's doing is very important. Uh, and important to have patients who are psychiatrically stable and don't have other immunologic diseases according to some criteria, again, not by label. Monitoring for ARIA with serial pre-scheduled MRIs is important, and the schedule is a little bit different depending on the antibody drug. For lecanemab, which is given by infusion, 10 milligrams per kilogram every 2 weeks, we have a pre-treatment MRI and then an MRI pre-scheduled before the 5th, 7th, and 14th infusion. For donanemab, which is given as by label 700 milligrams every 4 weeks for 3 doses, and then 1400 milligrams every 4 weeks thereafter, we have again the pre-treatment MRI plus an MRI before the second, third, fourth, and seventh dose. So with lecanemab, 3 MRIs post initiation of treatment, with donanemab, 4 MRIs within the first 6 months or so. And in addition, unscheduled MRIs may be necessary if people develop symptoms suggestive of ARIA in between these times. Now, here's a complicated chart, but a very handy one to have as a reference, which indicates for ARIA-E, and we'll look at ARIA-H in a moment, what you should do about this in terms of continuing dosing, temporarily suspending dosing, or permanently discontinuing dosing. And it depends on 2 factors. One is whether there are symptoms and how severe the symptoms are, and what the radiologic picture is. Do we have mild, moderate, or severe radiologic ARIA-E? So if we look at an example here, someone who is asymptomatic and is found on MRI imaging to have mild ARIA-E, we would continue dosing, but we would still do monthly MRI monitoring to ensure that that ARIA-E is resolving, not increasing. If we look at another example, severe symptoms now, going from asymptomatic to severe symptoms across the board, we would be either holding the dose until symptoms resolve and we get radiologic resolution, or by the appropriate use recommendations, which are more stringent, we would be permanently discontinuing dosing. So I'll leave this chart for your perusal at your own pace. Here's an example, though, of someone with mild ARIA E, so radiologically mild. It is where the red arrow is pointing a sulcal effusion on FLAIR imaging, and the patient is asymptomatic. This would be a case where it would be deemed safe to continue dosing, and we would monitor with monthly MRIs to ensure that this effusion recedes and disappears. Here's another example. Again, an asymptomatic patient, but this time radiologically, the ARIA E that we see, edema, is moderate. And it's moderate because it's multifocal and because of the size of the most prominent lesion. But multifocal ARIA-E radiologically, even without any symptoms, puts us in a situation where we need to hold treatment and wait until ARIA resolves. So importantly, we're not waiting till symptoms resolve here. The patient has no symptoms. We're waiting until the ARIA radiographically resolves, and then we can resume dosing. Let's look at ARIA-H. Similar concept. You need to know if the patient's symptomatic and how severe the symptoms are, and you need to know the severity from an MRI perspective. So asymptomatic ARIA-H, this could be superficial siderosis or microbleeds. We would continue dosing with monthly MRIs to make sure ARIA-H stabilizes. It's not going to disappear like ARIA-E. We're always going to see the signature of hemosiderin on the MRI, but we don't want to see more microbleeds or larger microbleeds. If we have moderate asymptomatic ARIA-H, we're going to suspend dosing and monitor to make sure we have stability. And let's go to an example of symptomatic ARIA-E, let's say not severe, but let's go to symptomatic ARIA-E with moderate radiographic severity. Again, suspend dosing, monitor with MRIs, make sure the symptoms this time and the ARIA stabilize. There are stopping criteria, permanent stopping criteria for ARIA, and they include by AUR the following: any new macrohemorrhage, more than one area of superficial siderosis that arises post-treatment, more than 10 microbleeds since the initiation of treatment. So it could be accumulation of microbleeds adding up to more than 10. More than 2 episodes of ARIA at 2 different time points. So if the patient's had a second episode of ARIA, even if it's mild, that may be a trigger to stop treatment. Any radiographic severe ARIA, serious ARIA symptoms, or a patient requiring treatment with an anticoagulant. And again, these are according to the AUR criteria, not specifically by label. So clinical judgment, discussion with patients, benefit risk analysis is key. What about patients in the emergency setting? It's important to realize that ARIA-E can present and mimic acute stroke. So one can develop acute focal findings with ARIA-E. And what we don't want to happen is for a patient with ARIA to be treated as if they have a stroke and receive thrombolytics. Thrombolytics have a risk of intracranial hemorrhage of 2 to 9%, and this risk is increased in patients taking amyloid-lowering antibodies. So how can we prevent this? We need to educate our emergency room colleagues and our radiology colleagues, as we've said before. We need to obtain an MRI. CT, although that's the usual practice for someone with acute stroke and emerge, is not going to be adequate to discern ARIA. We want to avoid use of thrombolytics. Deaths have occurred in this scenario of patients on anti-amyloid monoclonal antibodies receiving thrombolytics. And we really want to avoid that. And we also want to treat the symptoms of severe ARIA if they are occurring, and these could be seizures, um, reduced level of consciousness. You want to make sure you treat those. So let's turn now to ongoing assessment. We want to know a patient is benefiting from the intervention they're receiving. And how are we going to do this? Is a single cognitive test going to be sufficient? Do we need a cognitive battery or battery that includes functional testing, clinical interviews of patients and care partners? Um, do we stop lecanemab or donanemab if the disease progresses to a certain clinical stage, moderate stage Alzheimer's? And what about burden? Can the treatments become too burdensome, too frequent requirement to attend an infusion center, um, fragile veins, too many MRIs? People can develop a burden, and that has to be taken into consideration. We also need to think about stopping criteria, and this may make more sense for donanemab than lecanemab because donanemab clears plaque-bound amyloid. And if you have a follow-up PET scan, let's say at 12 months, and all amyloid is cleared on the PET scan, then there may be no further benefit to derive from continuing donanemab treatments. It's a little bit different with lecanemab because lecanemab reduces amyloid plaque, but also targets even more so protofibrils, which are not seen on a PET scan. So you're clearing ongoing, newly produced protofibrils as well. So again, you have to think about stopping criteria and what makes sense in the individual situation, given the antibody and the patient's response. So, to sum up, we have phase 3 data, robust data that shows that both lecanemab and donanemab are effective in lowering amyloid levels and slowing clinical progression of disease. They are appropriate for patients who have the mild cognitive impairment or mild dementia stage of Alzheimer's and who are biologically confirmed to have amyloid pathology. Patients need to be monitored clinically and with serial MRIs for safety. And continuing treatment is an ongoing discussion with patients and families and needs to take into account risk, benefit, feasibility, burden, and the values of the individual patients and families. Thank you for your attention, and please continue on to answer the questions that follow and complete the evaluation.